Hello, and welcome to another episode of the Health Data Ethics Podcast. I'm your host, Jenny Owens, and I'm so excited to have a guest with me today. Do you want to go ahead and introduce yourself?
Hi, Jenny. My name is Kumar Subramaniam, and I'm the CEO of a company called SafeTower. We spun out of Johns Hopkins last year.
This is so exciting. I know you and I had a chance to connect. Actually, I think it's been a couple months since we had a chance to
Mhm.
connect and talk through some of your really interesting thoughts on patient safety and how to use technology to make the entire health system safer, to reduce the burden on reporting and to sort of reduce some of the maybe the cultural burden on reporting too, because there's this sort of feeling like you don't want to say that you've gotten something wrong. Nobody wants to point fingers,
Mhm.
and I love the idea of using tech to make that a little bit easier. So, without further ado, I wanted to dive in and ask you for a little bit of a history lesson on SafeTower, your product. What does it do? How is it conceived? Give us a brief summary.
Sure. I think it's worth setting the context in terms of, how many lives are at stake here. On an annual basis, about a quarter of a million lives are lost in hospitals because medical errors occur to patients when they're admitted. That translates to roughly about 1 in 10 patients in the hospital and 1 in 4 patients in ambulatory settings. So when we were at Johns Hopkins, we figured that there was time to do something about it. There was this seminal study done almost 20 years ago, and it was published. The title was To Err is Human. And there was some movement made in terms of improving patient safety, but we realized that it was not going as fast as we would want it to. So we set about creating an entire new way of looking at patient safety. The problem was that people were focusing on just meeting the regulatory requirements, and they got sidetracked from actually implementing safety improvement initiatives. So we decided to kind of step in there and say, okay, here's what we're going to do. And we thought that there was a huge opportunity for using qualitative information to understand what really happens when a safety event occurs. The systems today basically are burdening front-end users with multiple forms. So if you want to report a fall, you have one form. If you want to report a medication event, you have another form, and so on and so forth. On average, we see about 20 forms, each with about 100 fields in there. Imagine the hapless nurse who's trying to report something that's happened seriously to one of her patients. And she has to first find the form, then find all the information needed to fill these forms. It was, and there's no shock that more than 85% of events don't go reported because of the burden involved here. So we decided that's the first thing that needs to change. And so we use machine learning, and innovative algorithms were used to basically parse through the nurse narrative and to identify the themes that were attached to that particular event that was being reported. And then we decided, wait a minute, that's not enough. We need to let all the people know that need to know what happened so that they can quickly jump in and say, okay, what do we do about this thing? Until today, it's very difficult for the nurse to find out where to send that particular event that she's trying to submit. She has to figure out whether or not the patient was harmed at level 1 or level 2 or level 5. We took away all of those burdens from the nurses. So we did all this between 2018 and 2021. We launched at Hopkins across the entire system, 6 hospitals, 500 ambulatory centers, surgery center, the home care group. And it launched on April 21, and it's been up and running for 3.5 years now. So talk about running the gauntlet, right? The entire system in one fell swoop. And then in April of 23, we decided to spin out of Hopkins and create SafeTower. So a few colleagues of mine, including safety and data science experts, we spun out of Hopkins with investment from Hopkins. And we've been trying to get to commercialization since then. So between when we launched and where we are today, we've also developed a very unique patient complaints and grievance solution that integrates into our patient safety solution simply because we were following the science like what we would do at Hopkins. So essentially, we found the research that says anytime a complaint or grievance is recorded, the likelihood of a safety event happening is 2.5 times. And so that was being ignored. So we decided to jump in there and fill that gap, if you will. So that's where we are today.
So you've brought me to one of the things that I really wanted to urge you to share more about, which was this integration of patient complaints and how this can actually strengthen a quality and safety program. Can you say more about that?
So imagine you're a leader, you're a patient experience leader, or you're a safety leader that's just come back from a risk management meeting, and your CEO or your CFO has asked you, hey, how are the risks trending in our organization? And until now, you didn't really have good options with you. You would have to go to your team separately, your patient experience team, your patient safety team, and ask them what's going on, what's trending, what's keeping us up awake at night, etc. And then you compile it manually, create a Excel spreadsheet, and then you don't know whether you actually got it right or not, because none of this is data driven and as an information set. So what we've done is basically created a software application that brings in the patient complaint or grievance and the safety event in a single dashboard that we can then allow users to export into an investigations module that people can collaborate on in real time to start looking at the problem holistically. Why did this patient complain about, or the patient's relative may have complained, oh, the nurse dropped my mother and she broke her hip. So that's a complaint, but there's also a safety event called the fall. Now, how do you make sure that the complaint and the fall are, simultaneously addressed so that it doesn't happen again? Maybe the nurse was overworked. Maybe the floor was slippery. Maybe and there's so many things that contributory factors that can happen. So we decided it's important to listen to the voice of the patient and their caregivers and use that as a valuable source of information in our analysis of improving patient safety in a hospital.
I think it's really interesting because it really gives kind of a weight and a dignity to the patient's experience as well. You know,
Mhm.
when we're talking about trying to make improvements and trying to make the hospital a safer place for patients, it's nice to have the patient voice also part of that discussion.
Yep.
Speaking of voices, I wanted to talk about your I guess your input approach, right? You mentioned that you were listening to nurse narratives and able to pick out information from that. Is this truly natural language reporting? So a nurse can just be grabbing, like a recording device or, speaking into a computer. And then I'd love to hear more about how that's been received by the end users.
Um, I'll give you one statistic. The rate at which Johns Hopkins began to see people um, receiving feedback from an event that they had reported jumped 167%
Ooh, tell me more about that. What does the
before and
feedback sound
after.
like? Yeah.
So it's essentially, think, and I'll give you one more statistic and I'll respond to your question. We also found a 30+% increase in physicians and attending doctors submitting events. So what does that mean? It means that we made the event reporting so ridiculously simple that it became very natural for people to actually pick up the phone, record something, or actually go into their phone and type out a two-page or a two-paragraph narrative on, hey, this is what happened, right? And for us to take the burden of saying, okay, let us parse this free text narrative using machine learning. Let us identify the themes that are existent in this data. So in order to understand what happens, what we do is we take a look at the historical events that have happened in the system, and we train our machine learning algorithms in there to create a safety event reporting taxonomy. And then we do the parsing of the narrative, and we look at cutoff scores to apply to a particular indicator or category in the taxonomy, and then we surface that up in the application so that somebody can take a look at it. And so what happens here is if you identify on average, say, 4 themes per event, then that event is tagged with those 4 themes and it is sent to a reviewing manager for their inputs or their analysis. So think about improving the quality of data captured so that you have a better understanding of what happened truly, as opposed to limiting yourself to one category or one team, if you will. So the reviewing manager now has the four categories, and it's up to her or him to take a look at what the machine has produced and say, that makes sense. It went to the privacy office here, it went to the health IT office there, it went to the falls committee there, but it missed this particular thing. And so we have the ability for the reviewing manager to interact with the machine. So think about this as a co-pilot approach. People talk about co-piloting AI. We've actually done it. So the reviewing manager actually can take a look at the tags and say, the machine missed this thing. I'm going to add it to this particular event because it missed this one perspective. And what we do is we learn from it. Every week, the machine retrains, and you can configure the machine to train, on a monthly interval, etc. The machine retrains, and the next time a similar event happens, the tagging of the event is that much more better, right? And so once these tags are created, the review managers looked at it, they can say, I wonder whether the reporter could tell me something more about this. And so there's a chat window in the application. It's almost like Twitter, if you will. And they can chat with the reporting nurse and say, tell me more about what happened here. Give me, some more detail. And that nurse gets an email. She or he can come in, provide more information. So what's happened at Hopkins, and I can speak to that experience, is the narrative has shifted from nobody listens to me, I don't get any feedback on whatever events are reported, to, yeah, it's fine that you responded to my event. It's fine that you're asking me questions. What have you done about it? So it's gone from nobody listens to me to now nurses and frontline staff feeling, I need somebody to tell me what they did with my information. And that's such a significant shift that we believe that that's the foundational building block for improving patient safety outcomes.
So this is really interesting, and I want you to go back and dig into something a little bit more for me. So
Happy to.
you mentioned getting to the what happened, right? Talk to me about your philosophy about picking out what happened versus why did this happen, and how does your system help with that sort of dividing line?
Yeah, that's a fantastic question. What we firmly believe in is that uh, unless you have a better description of what happened, a more fuller description of what happened, you can't do the right kinds of analyses. You can't have the right kinds of conversations. You can't have the right kinds of collaborations. You can't even have the necessary departments at the table to have these conversations, right? Now, for example, you can say that somebody fell and you record it as a fall. You don't record the fact that that patient had not eaten their food that day and they were malnourished and they were weak and they fell. So once our system identify all those details, the fact that they were malnourished and that they fell and something else happened, now we can get to a better place where analysis can happen. Now, people confuse between what happened and why it happened, right? Getting to the why requires you to actually do meaningful analysis and involve all of the right stakeholders in doing such analysis to say, okay, we now understand what's going on here, meaning to say, what were the contributory factors that we need to pay attention to so that we can implement improvement actions. Maybe we need to change our policy around how we deal with malnutrition. Maybe we need to change our policy around how the floors are waxed or washed or what have you. And then we need to implement them. So getting to the whys is basically trying to get to, okay, we understand the contributive factors. We think that this is the most important priority to deal with. Others can happen as resources allow, and then to be able to track those action items and to completion, if you will. Now you can imagine that full virtuous cycle where you do all these things and then you watch whether that event happens again or not. And then you realize, oh, maybe we didn't get all the contributor factors. Here's what we do. So it's a game of I'm using a strange term, a game of whack-a-mole, if you will.
Yeah.
But if you can't do any of that unless you have information that you need, right?
Mhm.
And it's very strange to us that currently the way the industry deals with it is by giving you those 20 forms to fill and the 140 fields to fill. Now imagine you're a frontline nurse and you've just wanted to report a fall on a patient. Do you have the time to tell me all the 70 required fields in addition to the narrative? The way the industry has treated it so far is that they believe that more data is better. We don't think so, and our research has shown that more data in healthcare is really not better. You need the right kind of information with the right kind of analysis to arrive at the right kinds of decisions, if you will. So that's where we're going.
Yeah. This is the song of my heart, right? More data is not necessarily better, but the right data absolutely is better. So as we're talking, the devil's advocate that sits on my shoulder is saying, okay, yeah, but what about risk, right? What's linked? What's discoverable? If we're integrating these systems, does this put our health system at increased risk if we're sued? Talk to me about. I'm sure I'm not the first person to raise this question. Talk to me about
Yeah,
how you're handling the idea of medical legal risk.
that's again a fantastic question. I'm so glad you asked it, and I'm so glad we're discussing it. One of the touch points, let me talk a little bit about integration points that any safety solution should have. So we integrate with the electronic medical record. We have an integration into Epic. So people can launch our application from the patient's chart in Epic. It's a soft launch in the sense that there is no trace of the launch. So there is nothing in Epic that is discoverable. So we know that the medical record is discoverable.
Mm-hmm.
But when you launch this, it's a soft launch. There's no trail left behind. So that's the first part of kind of insulating ourselves from the discoverability problem. Then when you launch it, depending on which jurisdiction or which state you're operating in, the nurse's narrative or the frontline narrative about this patient, this happened to him at this time, it is likely that that portion is discoverable. Any other subsequent tagging or analysis or follow through or collaboration or action item planning, those are all peer review privilege protected work product, right? So that's one of the reasons why, even though we pull the patient's chart from Epic, we don't send anything back into Epic. We keep it, everything is in our system, the follow-up, who's touched the record, all of the audit trail information, everything is stored in our system. So that's, a very high-level way to look at legal risk or discoverability risk when it comes to safety data. There is a difference, however, in terms of reputational risk.
Mm-hmm.
There is a difference in terms of claims risk. So now we are getting into this area. Your risk has many dimensions. So when you think about reputational risk, when you think about monetary or claims risk, you get into different areas where you're not just looking at information retrospectively, you're now wanting to go into the prospective area of safety. And I think that's an area where people really don't pay much attention to, which is they're so focused on solving for the regulatory reporting requirements. Right? Every state does it differently, and not all hospital systems deal with them the same way, but 80% of the time is spent answering the regulator or providing the regulator with information about safe sentinel events that happened in a hospital. They get nothing back, by the way, from the regulator. So all that is time wasted that could have otherwise been spent in making improvements in the system.
Mm-hmm.
So now what we think is important, and that's why I think looking at the descriptive narrative applying machine learning and natural language processing techniques to such data helps you also identify things that are low harm or no harm, essentially near misses. It's not a big leap of imagination to say, if we were to focus on these near misses and see the trends in the near misses, you can actually anticipate when something is going to transition over from being a near miss to an actual event that causes adverse harm. So now you're looking at the reputational aspect. You're getting ahead of the curve to say, ooh, these falls are happening much more frequently, or the near misses that we recorded in this particular unit have been increasing. Let's figure out what's happening in that unit before we have a real fall. And I'm giving an example. A medication error is a typical example where you could say, why are people being misdosed in a particular facility or in a particular department? What's happening? Why did we have so many near misses here? Has there been too much attrition? Has the instructions for medication not clear? Is there something wrong with Epic in terms of how the prescriptions are being told? So you know what I mean? So getting ahead of the curve means looking at near miss data. You can't look at near miss data if you don't capture it, if you don't classify it. So we're also now, eagerly analyzing information that we have to say, how can we create algorithms that help you identify near miss? Now, what we do today, of course, are two, here and now things. We can help you find out what similar events that are similar to this one that you're reporting or reviewing have happened across the system. There was no way for you to know that before we came along. So when you open your reviewing dashboard, you can actually take a list, look at the list of similar events that have happened, not on the same patient, but a different patient in a different location. And then you're able to see, how did that department handle that particular event? Can I learn something from it? Can I call those people? So now you're creating a learning network. And so that's the similar event problem.
Yeah, and being able to place an individual event in the context of the broader enterprise is tremendously helpful. And being able to move, possibly in the future, to preventing things, to being able to predict near misses and then prevent actual events from happening would be tremendously powerful. We are coming up on time, and I am so, so grateful for your time today. Before we close, is there any question you want to answer, anything else you want to say that I haven't asked you yet?
No, this has been fantastic, and I wish we have some more time in the future to talk about the integration between complaints, grievances, and safety information, because an area of discussion that deserves a lot more attention. I'm so thankful to you, Jennifer, for making this time and for chatting with me.
I'm so grateful that we connected, and I'm so grateful that you were able to share a little bit about your technology. This has been wonderful. Thank you so much.
Thank you.